Lewis's Medical Surgical Nursing, 11th edition, Chapter 63, Musculoskeletal Problems. We were made to move. This chapter reviews a variety of acute and chronic musculoskeletal problems related to trauma that affect the musculoskeletal system. These include osteomyelitis, bone cancer, foot disorders, back pain, and metabolic bone diseases. These problems can lead to changes in mobility that affect almost every system in the body. They are a common source of pain and physical limitations that restrict the ability to fully take part in activities of daily living, ADLs, leading to disability. The nurse plays a key role in assessing pain and functional ability and initiating interventions to prevent injury and maintain mobility. Osteomyelitis, etiology and pathophysiology. Osteomyelitis is a severe infection of the bone marrow, and surrounding soft tissue. Although Staphylococcus aureus is the most common cause of infection, a variety of pathogens can cause osteomyelitis. Infecting microorganisms can invade by direct or indirect entry. Indirect entry, hematogenous, is usually associated with infection with one microorganism. Indirect injury counts for only 20% of all cases. It most often affects children younger than 17 years. Risk factors in adults are older age, debilitation, hemodialysis, sickle cell disease, and IV drug use. The vertebrae are the most common site of infection in adults. Direct entry osteomyelitis most often affects adults. It can occur when an open wound, e.g. penetrating wounds, fractures, surgery, allows microorganisms to enter the body. Osteomyelitis also may be related to a foreign body, such as an implant or an orthopedic prosthetic device, e.g. plate, total joint prosthesis. It may occur in the feet of patients with diabetes or vascular disease-related ulcers, or in the hips or sacrum near a pressure injury. More than one microorganism is usually involved. After entering the blood, microorganisms grow and pressure increases because of the non-expanding nature of most bone. This increasing pressure eventually leads to ischemia and vascular compromise of the periosteum. The infection spreads through the bone cortex and marrow cavity, obstructing blood flow and causing necrosis. Bone death occurs due to ischemia. The area of dead bone eventually separates from the surrounding living bone, forming sequestra. The part of the periosteum that continues to have a blood supply forms new bone called involucrum. Antibiotics or white blood cells, WBCs, have difficulty reaching the sequestrum through the blood. Thus, sequestrum may become a reservoir for microorganisms that spread to other sites, including the lungs and brain. If the sequestrum does not resolve or is not debrided surgically, a sinus tract may develop. Chronic, purulent, cutaneous drainage from the tract results. Clinical manifestations and complications. Acute osteomyelitis refers to the initial infection or an infection of less than 1 month in duration. Local manifestations of acute osteomyelitis include constant bone pain that worsens with activity and is unrelieved by rest, swelling, tenderness, and warmth at the infection site, and restricted movement of the affected part. Systemic manifestations include fever, night sweats, chills, restlessness, nausea, and malaise. Later signs include drainage from cutaneous sinus tracts or the fracture site. Chronic osteomyelitis refers to a bone infection that lasts longer than 1 month, or an infection that did not respond to initial antibiotic treatment. Chronic osteomyelitis may be a continuous, persistent problem, a result of inadequate acute treatment, or a process of exacerbations and remissions. Systemic manifestations are lessened. Local signs of infection become more common, including constant bone pain and swelling, and warmth at the infection site. Over time, granulation tissue turns to scar tissue. The avascular scar tissue is an ideal site for continued microorganism growth because it cannot be penetrated by antibiotics. Long-term and mostly rare complications of osteomyelitis include septicemia, septic arthritis, pathologic fractures, and amyloidosis. Diagnostic studies. Bone or soft tissue biopsy is the definitive way to identify the causative agent. The patient's blood and wound cultures are often positive. Increased WBC count and erythrocyte sedimentation rate (ESR) may occur. High C-reactive protein (CRP) may occur with acute infection. Signs of osteomyelitis usually do not appear on X-rays until 2 to 4 weeks after the initial clinical symptoms. By this time, the disease will have progressed. Compared to X-rays, CT scan may be more helpful in assessing the extent of infection. In the acute phase, MRI may be more sensitive than CT in detecting bone marrow edema, which is an early sign of osteomyelitis. Radionuclide bone scans, Technicum 99M, also show abnormalities earlier than X-rays. A WBC scan, indium 111 labeled cells, may help pinpoint the area of infection. Interprofessional care. Aggressive, prolonged IV antibiotic therapy is the treatment of choice for acute osteomyelitis if bone ischemia has not yet occurred. Cultures or a bone biopsy should be done, if possible, before starting drug therapy. Any related soft tissue abscess or ulceration often needs surgical debridement or drainage. IV antibiotic therapy starts in the hospital and then continues at home for 4 to 6 weeks. A few persons need therapy for 3 to 6 months. Patients may be discharged to home care or a skilled nursing facility, so the antibiotics can be given through a central venous access device, CVAD. A variety of antibiotics are used, depending on the culture results and likelihood of resistance. These include oxacillin, nafcillin, clindamycin, vancomycin, ceftriaxone, cefazolin, ceftizidime, gentamicin, and linezolid. Treatment of chronic osteomyelitis includes 1. Surgical removal of the poorly perfused tissue and dead bone, and 2. Extended use of antibiotics. In adults with chronic osteomyelitis, oral therapy with a fluoroquinolone, e.g. ciprofloxacin, Cipro, for 6 to 8 weeks may be prescribed instead of IV antibiotics. Oral antibiotics also may be given for 4 to 8 weeks after acute IV therapy is done to ensure the infection is resolved. Patient's response to drug therapy is monitored through bone scans and ESR testing. Acrylic bead chains containing antibiotics may be implanted to help combat the infection. After debridement of the dead infected tissue, a suction irrigation system may be inserted and the wound closed. Intermittent or constant irrigation of the area with antibiotics may be used. Another option for wound management is negative pressure wound therapy. Casts or braces may be applied to protect the limb or the surgical site. Hyperbaric O2 may be given as an adjunct therapy in refractory cases of chronic osteomyelitis. It stimulates new blood growth and healing in the infected tissue. If an orthopedic prosthetic device is the source of chronic infection, it must be removed. Muscle flaps or skin grafts provide wound coverage over the dead space, cavity, in the bone. Bone grafts may help to restore blood flow. However, flaps or grafts should never be placed in the presence of active or suspected infection. Amputation of the extremity may be needed if bone destruction is extensive. Amputation should improve quality of life and may save the patient's life if systematic complications are developing. Nursing management, osteomyelitis. Nursing diagnoses. Nursing diagnoses for the patient with osteomyelitis may include acute pain, impaired physical mobility, lack of knowledge. Planning. The overall goals are that the patient with osteomyelitis will 1. Have satisfactory pain and fever management, 2. Not have any complications associated with osteomyelitis, 3. Adhere to the treatment plan, and 4. Maintain a positive outlook on the outcome of the disease. Nursing implementation. Health promotion. Control of other current infections, e.g. urinary or respiratory tract pressure injuries, is important in preventing osteomyelitis. Persons at risk for osteomyelitis are those who are immunocompromised or have diabetes, orthopedic prosthetic implants, or vascular insufficiency. Teach the at-risk patient about the local and systemic signs of osteomyelitis. Encourage the patient to contact the HCP about bone pain, fever, swelling, and restricted limb movements so that treatment can be started. Teach caregivers about their role in monitoring the patient's health. Acute care. Some immobilization of the affected limb, e.g. splint traction, is usually needed to decrease pain and reduce risk for further injury. Carefully handle the limb and avoid undue manipulation. This may increase pain and cause a pathologic fracture. Assess the patient's pain. Muscle spasms may cause minor and severe pain. NSAIDs, drugs, opioid analgesics, and muscle relaxants may be given. Encourage non-drug approaches to pain management, e.g. guided imagery, relaxation breathing. Dressings are used to absorb drainage from wounds and debris dead tissue from the wound bed. These include dry, sterile dressings, dressings saturated in saline or antibiotic solution, wet to dry dressings, and dressings applied with negative pressure wound therapy. Sterile techniques is essential when changing the dressing. Handle soiled dressings carefully to prevent transfer of bacteria to other areas of the wound. Discard dressings appropriately to prevent spread of infection to other patients. The patient is often placed on bed rest in the early stages of acute infection. Good body alignment and frequent position changes promote comfort and prevent complications related to immobility. Flexion contracture of the affected lower extremity is common as the patient often positions the leg in a flexed position to promote comfort. Foot drop can develop quickly due to Achilles tendon contracture if the foot is not supported in a neutral position by a splint or boot. A tight splint or dressing may compress and injure the peroneal nerve. Teach the patient the possible adverse and toxic reactions associated with prolonged high-dose antibiotic therapy. These reactions include hearing deficit, impaired renal function, and neurotoxicity, e.g. limb weakness or numbness, cognitive changes, vision changes, headache, behavioral problems. Reactions associated with cephalosporins, e.g. cefazolin, include hives, severe or watery diarrhea, blood in stools, and throat or mouth sores. Tendinitis or tendon rupture, especially the Achilles tendon, can occur with use of fluoroquinolones, e.g. ciprofloxacin. Monitor peak and trough blood levels of most antibiotics to avoid adverse effects. Lengthy antibiotic therapy can cause an overgrowth of Candida albicans and Clostridium difficile in the GU and GI tracts, especially in immunosuppressed and older adult patients. Teach the patient to report any changes in the oral cavity, e.g. whitish yellow curd-like lesions, or the GU tract, e.g. perianal itching, discharge. The patient and caregivers may be anxious and discouraged because of the serious nature of osteomyelitis and the uncertainty of the outcome and the long, costly treatment. Continued psychologic and emotional support is an integral part of nursing management. Ambulatory care. IV antibiotics can be given to the patient in a skilled nursing facility or home setting. If at home, teach the patient and caregiver how to manage the CVAD. Review how to administer the antibiotic and reinforce the need for follow-up laboratory testing. Stress the importance of continuing to take the full course of antibiotics prescribed, even after symptoms have improved. Dressing changes are often needed if the patient has an open wound. Patient and caregiver may need supplies and instruction for completing the dressing change. If the osteomyelitis becomes chronic, patient needs continued physical and psychological support. Evaluation. Expected outcomes are that the patient with osteomyelitis will have satisfactory pain management, adhere to the recommended treatment plan, show a consistent increase in mobility and range of motion. Bone tumors. Primary bone tumors, both benign and malignant, are rare in adults. They account for only about 3% of all tumors. Metastatic bone cancer, in which cancer has spread from another site, is a more common problem. Benign bone tumors. Benign bone tumors are more common than primary malignant tumors. The main types of benign bone tumors are osteochondroma, osteoclastoma, and enchondroma. They're often removed surgically. Osteochondroma. Osteochondroma is the most common primary benign bone tumor. It is characterized by an overgrowth of cartilage and bone near the end of the bone at the growth plate. They most often occur in the pelvis, scapula, or long bones of the leg. Manifestations include a painless, hard, immobile mass, shorter than normal height for age, soreness of muscles close to the tumor, one leg or arm longer than the other, and pressure or irritation with exercise. Some may be asymptomatic. Diagnosis is confirmed using X-ray, CT scan, and MRI. No treatment is needed for asymptomatic osteochondroma. Patients should have regular screening examinations to detect progression to cancer as soon as possible. If the tumor is causing pain or neurologic manifestations because of compression, surgical removal is usually done. Malignant bone tumors. A sarcoma is a malignant tumor that develops in bone, muscle, fat, nerve, or cartilage. The most common types of sarcomas are osteosarcoma, chondrosarcoma, and Ewing's sarcoma. In 2018, 3,450 new cases of bone and joint cancer are expected in the United States, with an estimated 1,590 deaths. Primary malignant tumors occur most often during childhood and young adulthood, cause bone destruction, and have rapid metastasis. Osteosarcoma. Osteosarcoma is an extremely aggressive primary bone cancer that rapidly spreads to distant sites. Usually occurs in the pelvis or metaphyseal region of the long bones of extremities, especially in the distal femur, proximal tibia, and proximal humerus. Osteosarcoma is the most common bone cancer affecting children and young adults. It can occur in older adults, but not as often. It is most often associated with Paget's disease and prior radiation. Gradual onset of pain and swelling in the affected bone are the most common manifestations. Pain may be worse at night and increase with activity. A minor injury does not cause the cancer, but may bring it to medical attention. Metastasis is present in 10 to 20% of people at the time of diagnosis. Diagnosis is confirmed from tissue biopsy, increased serum alkaline phosphatase and calcium, X-ray, CT or PET scans, and MRI. Preoperative chemotherapy may be used to decrease tumor size before surgery. Limb salvage procedures are usually considered if a clear no cancer present. 6 to 7 centimeter margin surrounds the lesion. Limb salvage is usually not possible if the patient has major nerve or blood vessel involvement, pathologic fracture, infection, or extensive muscle involvement. The use of adjunct chemotherapy after amputation or limb salvage has increased the 5-year survival rate to 70% in people without metastasis. Chemotherapy includes combinations of methotrexate, doxorubicin, cisplatin, ifosfamide, cyclophosphamide, and etoposide. Metastatic bone cancer. The most common type of malignant bone tumor occurs because of spread metastasis from a primary tumor at another site. Common primary sites include breast, colon, prostate, lungs, kidney, and thyroid. Metastatic cancer cells travel from the primary tumor to the bone via the lymph and blood supply. Metastatic bone lesions occur often in the spine, ribs, or pelvis. Pathologic fractures at the site of metastasis are common because the bone is weakened. High serum calcium occurs as damaged bones release calcium. Once a primary lesion has been found, radionuclide bone scans are often done to detect metastatic lesions before they are visible on X-ray. Metastatic bone lesions may occur at any time, even years later, after diagnosis and treatment of the primary tumor. Bone metastasis should be suspected in any patient who has local bone pain and a history of cancer. Surgical stabilization of the bone may be indicated for fracture or to prevent fracture in a high-risk patient. Prognosis depends on the primary type of cancer and any other sites of metastasis. Possible palliative treatment consists of radiation and pain management. Nursing management, bone cancer. Nursing care of the patient with bone cancer does not differ significantly from the care provided to the patient with cancer of any other body system. Monitor the tumor site for swelling, changes in circulation, and decreased movement sensation or joint function. Use special care to prevent pathologic fractures and reduce the complications associated with them. Prevent fractures by careful handling and support of the affected extremity and log rolling the patient on bed rest. Note weakness caused by anemia and decreased mobility. Treatment for hypercalcemia may be started if bone decalcification occurs. Patient may be unwilling to exercise or take part in activities because of weakness from the disease and treatment, fear of falling and fracturing a bone, and fear of pain. Provide regular rest periods between activities. Assess the patient for the location and severity of pain. The pain associated with bone cancer can be severe. It is often caused by the tumor pressing against nerves and other organs near the bone. New onset or changes in pain severity may indicate pathologic fracture. Ensure adequate pain medication is provided. Sometimes radiation therapy is used as a palliative therapy to shrink the tumor and decrease pain. Assist the patient and caregiver in accepting the prognosis associated with bone cancer. Give special attention to problems of pain and disability, side effects of chemotherapy, and postoperative care, e.g., spinal cord decompression or amputation. As with all types of cancer, stress the importance of follow-up examinations. Muscular dystrophy. Muscular dystrophy, MD, is a group of genetic diseases characterized by progressive symmetric wasting of skeletal muscles without evidence of neurologic involvement. A gradual loss of strength with increasing disability and deformity occurs with all forms of MD. The types of MD differ in the groups of muscles affected, age of onset, rate of progression, and mode of genetic inheritance. Duchenne MD is the most common type. Genetic link. Duchenne and Becker MD are X-linked recessive disorders usually seen only in males. These disorders are caused by a mutation of the dystrophin DMD gene. Dystrophin is a protein that helps keep skeletal muscle fibers intact. Abnormal dystrophin can cause defects in the muscle fiber and muscle fiber degeneration. Genetic testing can detect a mutation in the DMD gene and confirm a diagnosis. Other diagnostic studies for MD include muscle serum enzymes, especially creatine kinase, electromyogram (EMG) testing, and muscle fiber biopsy. Classic findings on muscle biopsy include fat and connective tissue deposits, muscle fiber degeneration and necrosis, and a deficiency of dystrophin. An ECG may show abnormalities that suggest cardiomyopathy. No definitive therapy is available to stop progressive muscle wasting of MD. Corticosteroid therapy is part of the standard of care. It may slow disease progression for up to 2 years. In 2017, the FDA approved 2 new medications to treat MD. Deflazacort, Emflaza, is the first corticosteroid approved to treat Duchenne MD. Eteplirsen, Exondys 51, is the first disease-modifying drug to treat Duchenne MD patients who have a certain dystrophin gene mutation. Other clinical trials underway involve gene therapy and stem cell transplantation. The main treatment goals are to preserve mobility and independence through exercise, physical therapy, and use of assistive devices. Progressive muscle weakening around the trunk can cause spinal collapse. The patient may be fitted early with an orthotic jacket to give stability and prevent further deformity or injury. Life expectancy is increasing due to advances in cardiac and respiratory care. Cardiomyopathy often occurs and causes heart failure. Dysrhythmias are a frequent cause of death. Gradual decreases in respiratory function often lead to the use of CPAP. Eventually, tracheostomy and mechanical ventilation are needed to support respiratory function. Encourage communication between the patient and family to cope with the emotional and physical demands of MD. Teach the patient and caregiver ROM exercises, principles of good nutrition, and signs of disease progression. Genetic testing and counseling may be recommended for persons with a family history of MD. Focus care on keeping the patient active as long as possible. Prolonged bed rest should be avoided because immobility can cause more muscle wasting. As the disease progresses, teach the patient to limit sedentary periods to prevent skin breakdown and respiratory complications. Ongoing medical and nursing care is needed throughout the patient's life. Muscular Dystrophy Association is an important resource with information about support services for the patient and caregivers. The website gives updates about the latest clinical trials and treatment advances. Low back pain. Low back pain is most often due to a musculoskeletal problem. It may be localized or diffuse. In localized pain, patients feel soreness or discomfort when a specific area of the lower back is palpated or pressed. Diffuse pain occurs over a larger area and comes from deep tissue. Low back pain may be radicular or referred. Radicular pain is caused by irritation of a nerve root. Radicular pain is not isolated to a single location. Instead, it radiates or moves along a nerve distribution. Sciatica is an example of radicular pain. Referred pain is felt in the lower back, but the source of the pain is another location, e.g., kidneys, lower abdomen. Low back pain affects about 80% of adults in the United States at least once during their lives. Backache is second only to headache as the most common pain problem. It is the leading cause of job-related disability and a major contributor to missed work days. Low back pain is common because the lumbar region 1 bears most of the weight of the body, 2 is the most flexible region of the spinal column, 3 has nerve roots that are at risk for injury or disease, and 4 has a naturally poor biomechanical structure. Risk factors include lack of muscle tone, excess body weight, stress, poor posture, smoking, pregnancy, prior compression fracture of the spine, spinal problems since birth, and a family history of back pain. Jobs that require repetitive heavy lifting, vibration, such as a jackhammer operator, and extended periods of sitting are associated with low back pain. Causes of low back pain of musculoskeletal origin include 1. Acute lumbosacral strain, 2. Instability of the lumbosacral bony mechanism, 3. Osteoarthritis of the lumbosacral vertebrae, 4. Degenerative disc disease, and 5. Herniation of an intervertebral disc. Healthcare personnel who perform direct patient care activities are at high risk for developing low back pain. Lifting and moving patients, excessive bending or leaning forward, and frequent twisting can result in low back pain that causes lost time and productivity and disability. Nurses should follow the agency's safe patient handling standards to avoid injury. Acute low back pain. Acute low back pain lasts 4 weeks or less. Most acute low back pain is caused by trauma or an activity that produces undue stress, often hyperflexion, on the lower back. Examples of trauma or activities that cause acute back pain are heavy lifting, overuse of back muscles during yard work, a sports injury, or a sudden jolt, as in a motor vehicle crash. Often symptoms do not appear at the time of injury. They develop later, usually within 24 hours, because of a gradual increase in pressure on the nerve from an intervertebral disc and/or associated edema. Symptoms may range from muscle ache to shooting or stabbing pain, limited flexibility or ROM, or an inability to stand upright. Few definitive diagnostic abnormalities are present with nerve irritation and muscle strain. One test is the straight leg raising test. MRI and CT scans are not done unless trauma or systemic disease, e.g. cancer, spinal infection, is suspected. MRI findings may be limited in the acute phase of an injury due to increased edema near the injury. Nursing and interprofessional management, acute low back pain. Nursing implementation. Health promotion. Serve as a role model by always using proper body mechanics. This includes increasing the patient's bed height, bending at the knees, asking for help in lifting and moving patients, and using lifting devices. Assess the patient's use of body mechanics and offer advice when the person does activities that could produce back strain. Some HCPs refer patients with back pain to a program called Back School. This formal program is usually taught by an HCP, nurse, or physical therapist. It is designed to teach the patient how to minimize back pain and avoid repeat episodes of pain. Referral to a physical therapist or personal trainer to address posture and core and abdomen strength may be appropriate. Recommend flat shoes or shoes with low heels and shock-absorbing shoe inserts for women. Advise patients to maintain a healthy body weight. Excess body weight places more stress on the lower back. It weakens abdominal muscles that support the lower back. Sleeping position is important in preventing low back pain. Teach patients to avoid sleeping in a prone position because it causes excessive lumbar lordosis, placing stress on the lower back. Sleeping in a supine or side-lying position with knees and hips flexed prevents pressure on support muscles, ligaments, and lumbosacral joints. Recommend use of a firm mattress. Teach patients the importance of smoking cessation. Tobacco use impairs circulation to the intervertebral discs and contributes to low back pain. Acute care. If acute muscle spasms and accompanying pain are not severe and unbearable, the patient is treated as an outpatient with NSAIDs and muscle relaxants, e.g., cyclobenzaprine, massage and back manipulation, acupuncture, and the application of cold and hot compresses may help some patients. Severe pain may require a brief course of corticosteroids or opioid analgesics. Some people may need a brief period, 1 to 2 days, of rest at home but should avoid prolonged bed rest. Most patients do better if they continue their regular activities. Patients should refrain from activities that increase the pain, including lifting, bending, twisting, and prolonged sitting. Symptoms of acute low back pain usually improve within 2 weeks and often resolve without treatment. Teach the patient about the cause of the pain, ways to prevent further episodes. Muscle stretching and strengthening exercises may be part of the management plan. Although the physical therapist often teaches the exercises, reinforce the type and frequency of prescribed exercise and the reason for the program. Other nursing interventions for the patient with low back pain are detailed, blah, 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 blah. Ambulatory care. The goal of management is to make an episode of acute low back pain an isolated incident. If the lumbosacral area is unstable, repeated episodes are likely. Obesity, poor posture, poor muscle support, older age, or trauma may weaken the lumbosacral spine, so it is unable to meet the demands placed on it without strain. Exercise is aimed at strengthening the supporting muscles. Persistent use of poor body mechanics may result in repeated episodes of low back pain. If the strain is work-related, occupational counseling may be needed. Low back pain can cause frustration, pain, and disability. Provide emotional support and understanding care of the patient. Chronic low back pain. Chronic low back pain lasts more than 3 months or involves a repeated incapacitating episode. It is often progressive and the cause can be hard to determine. Causes include 1. Degenerative conditions such as arthritis or disc disease, 2. Osteoporosis or other metabolic bone diseases, 3. Weakness from the scar tissue of prior injury, 4. Chronic strain on lower back muscles from obesity, pregnancy, or stressful postures on the job, and 5. Congenital spine problems. Spinal stenosis. Spinal stenosis is a narrowing of the spinal canal, which holds the spinal cord. Stenosis in the lumbar spine is a common cause of chronic low back pain. Spinal stenosis can be acquired or inherited. A common acquired cause is osteoarthritis. Arthritic changes, bone spurs, calcification of spinal ligaments, disc degeneration, narrow the space around the spinal canal and nerve roots, eventually leading to compression. Inflammation caused by the compression results in pain, weakness, and numbness. Other acquired conditions that may cause spinal stenosis include rheumatoid arthritis, spinal tumors, Paget's disease, and traumatic damage to the vertebral column. Inherited conditions that lead to spinal stenosis include congenital spinal stenosis and scoliosis. Pain associated with lumbar spinal stenosis often starts in the lower back, then radiates to the buttock and leg. It is worse with walking or prolonged standing. Numbness, tingling, weakness, and heaviness in the legs and buttocks may be present. History of decreased pain when the patient bends forward or sits is often a sign of spinal stenosis. In most cases, stenosis slowly progresses. Interprofessional and nursing care. Management and treatment of chronic low back pain are similar to those for acute low back pain. Manage the patient's pain and stiffness with mild analgesics such as NSAIDs for daily comfort. Antidepressants, e.g. duloxetine, Cymbalta, may help with pain management and sleep problems. The anti-seizure drug gabapentin, Neurontin, may improve walking and relieve leg symptoms. Weight reduction, rest periods, local heat or cold application, physical therapy, and exercise and activity throughout the day help keep the muscles and joints mobilized. Cold, damp weather worsens the back pain. Pain can be decreased with rest and local heat application. Complementary and alternative therapies such as biofeedback, acupuncture, and yoga may help reduce the pain. Back school can significantly reduce pain and improve body posture. Minimally invasive treatments such as epidural corticosteroid injections and implanted devices that deliver pain medication are options for those with chronic low back pain that does not respond to the usual therapeutic options. Surgical intervention may be indicated in patients with severe chronic low back pain who receive no benefit from conservative care and or have continued neurologic deficits. Intravertebral disc disease. Intervertebral discs separate the vertebrae and help absorb shock for the spine. Intervertebral disc disease involves the deterioration, herniation, or other dysfunction of the intervertebral discs. Disc disorders can affect the cervical, thoracic, and lumbar spine. Etiology and pathophysiology. Degenerative disc disease, DDD, results from loss of fluid in the intervertebral discs with aging. The discs lose their elasticity, flexibility, and shock-absorbing abilities. Unless it is accompanied by pain, DDD is a normal process. The discs become thinner as the nucleus pulposus, gelatinous center of the disc, starts to dry out and shrink. This change limits the disc's ability to distribute pressure between vertebrae. Pressure is then transferred to the annulus fibrosus, strong outside part of the disc, causing progressive destruction. When the disc is damaged, the nucleus pulposus may seep through a torn or stretched annulus. This is called a herniated disc, slipped disc, a condition in which a spinal disc bulges outward between the vertebrae. A herniated disc can result from degeneration with age or repeated stress and trauma to the spine. The most common sites of herniation are the lumbosacral discs, specifically L4 to 5 and L5 to S1. Disc herniation may also occur at C5 to 6 and C6 to 7. It may be the result of spinal stenosis, in which narrowing of the spinal canal forces the intervertebral disc to bulge. Spinal nerves emerge from the spinal column through an opening into vertebral foramen between adjacent vertebrae. Herniated discs can press against these nerves, pinch nerve, causing radiculopathy, radiating pain, numbness, tingling, decreased strength and/or range of motion. Osteoarthritis, OA, of the spine is associated with DDD and the stresses placed on the vertebrae. As the poorly lubricated joints rub against each other, the protective cartilage is damaged and painful bone spurs occur as one of the changes found in OA. Clinical manifestations. In lumbar disc disease, the most common manifestation is low back pain, radicular pain that radiates down the buttock and below the knee along the distribution of the sciatic nerve generally indicates disc herniation. Specific manifestations of lumbar disc herniation are outlined in Table 63.7. A positive straight leg raising test may indicate nerve root irritation. Back or leg pain may be reproduced by raising the leg. Low back pain from other causes may not be accompanied by leg pain. Reflexes may be depressed or absent depending on the spinal nerve root involved. Numbness and tingling, paresthesia, or muscle weakness in the legs, feet, or toes may occur. Multiple lumbar nerve root compressions, cauda equina syndrome, from a herniated disc tumor or an epidural abscess may be marked by 1. Severe low back pain, 2. Progressive weakness, 3. Increased pain, 4. Bowel and bladder incontinence or retention. Saddle anesthesia, loss of or altered sensation of the perineum, buttocks, inner thighs, and back of the legs, saddle area, may be present. Symptoms of cauda equina syndrome may develop suddenly or evolve slowly over time. It may vary in intensity. Cauda equina is a medical emergency that requires surgical decompression to reduce pressure on the nerves and prevent permanent paralysis. In cervical disc disease, pain radiates into the arms and hands following the pattern of the involved nerve. Like lumbar disc disease, reflexes may or may not be present. The hand grip is often weak because manifestations of cervical disc disease may include shoulder pain and dysfunction. The HCP must rule out shoulder disorders as part of the diagnosis. Diagnostic studies. X-rays are done to detect any structural defects. A myelogram, MRI, or CT scan is helpful in localizing the damage site. An epidural venogram or discogram may be needed if the other diagnostic studies are inconclusive. An EMG of the extremities can be done to determine the severity of nerve irritation or to rule out other conditions, such as peripheral neuropathy. Interprofessional care. Patient with suspected disc damage is usually managed with conservative therapy. This includes limitation of extremes of spinal movement, e.g. brace, corset, belt, local heat or ice, ultrasound and massage, traction, and transcutaneous electrical nerve stimulation, TENS. Drug therapy to manage pain includes NSAIDs, short-term oral corticosteroids, opioid analgesics, muscle relaxants, anti-seizure drugs, and antidepressants. Epidural corticosteroid injections may reduce inflammation and relieve acute pain. However, Pain tends to recur if the underlying cause remains. When symptoms subside, the patient should begin back strengthening exercises twice a day and continue for life. Teach the patient the principles of good body mechanics. Discourage extremes of flexion and torsion. With a conservative treatment plan, most patients heal after 6 months. Surgical therapy. If conservative treatment is unsuccessful, radiculopathy becomes worse, or loss of bowel or bladder control occurs. Surgery may be considered. Surgery for a damaged disc is generally done if the patient is in constant pain and/or has a persistent neurologic deficit. Intradiscal electrothermoplasty (IDET) is a minimally invasive outpatient procedure for treatment of back and sciatic pain. A needle is inserted into the affected disc with X-ray guidance. A wire is then threaded through the needle and into the disc. As the wire is heated, small nerve fibers that have invaded the degenerating disc are destroyed. The heat also partially melts the annulus fibrosus. This causes the body to generate new reinforcing proteins in the fibers of the annulus. Other outpatient technique is radiofrequency discal nucleoplasty, coablation nucleoplasty. A needle is inserted into the disc similar to IDET. Instead of a heated wire, a special radiofrequency probe is used. The probe generates energy that breaks the molecular bonds of the gel in the nucleus pulposus. Up to 20% of the nucleus is removed. This decompresses the disc and reduces pressure on the disc and surrounding nerve roots. Subsequent pain relief varies. A third procedure involves use of an intraspinous process decompression system, X-stop. This titanium device fits onto a mount that is placed on vertebrae in the lower back. The X-stop is used in patients with pain due to lumbar spinal stenosis. The device works by lifting vertebrae off of the pinched nerve. Laminectomy is a common traditional surgical procedure for lumbar disc disease. It involves surgical excision of part of the vertebra, referred to as the lamina, to access and remove the protruding disc. Laminectomy is often done as an outpatient procedure. However, a hospital stay of 1 to 3 days is not uncommon. Discectomy also can be done to decompress the nerve root. Microsurgical discectomy is a version of the standard procedure. The HCP uses a microscope to better see the disc and disc space, which helps in removal of the damaged portion. This helps maintain bony stability of the spine. Percutaneous discectomy is a safe and effective outpatient surgical procedure. A tube is passed through the retroperitoneal soft tissues to the disc with the aid of fluoroscopy. A laser is then used on the damaged part of the disc. Minimal blood loss occurs because of access through small stab wounds. The procedure decreases rehabilitation time. The goals of artificial disc replacement surgery are to restore movement and eliminate pain. The Charité disc is used in patients with lumbar disc damage associated with DDD. This artificial disc has a high-density core sandwiched between two cobalt chromium end plates. After removing the damaged disc, the device is surgically placed in the spine, usually through a small incision below the umbilicus. The disc restores movement at the level of the implant. The ProDisc L is another type of artificial lumbar disc used to treat DDD. Options for treatment of DDD of the cervical spine include the Prestige cervical disc, Mobi C disc, and Secure C artificial cervical disc. A spinal fusion may be needed if the spine is unstable. The spine is stabilized by creating ankylosis, fusion, of adjacent vertebrae with a bone graft from the patient's fibula or iliac crest, autograft, or from donated cadaver bone, allograft. Metal fixation with rods, plates, or screws may be placed to give more stability and decrease vertebral motion. A posterior lumbar fusion may be done to give extra support for bone grafting or a prosthetic device. Bone morphogenetic protein, BMP, a genetically engineered protein, may be used to stimulate bone growth of the graft in spinal fusions. A dissolvable sponge soaked with BMP is implanted into the spine. BMP on the sponge stimulates the body's cells to become active and produce bone, promoting fusion. The body absorbs the sponge, leaving living bone behind. Nursing management, vertebral disc surgery. After vertebral disc surgery, a key focus of nursing interventions is maintaining proper alignment of the spine until it is healed. Depending on the type and extent of surgery and the HCP's preference, the patient may be able to dangle the legs at the side of the bed, stand, or even ambulate the day of surgery. After lumbar fusion, place pillows under the patient's thighs when supine and between the legs when in the side-lying position to provide comfort and ensure alignment. The patient often fears turning or any movement that may increase pain by stressing the surgical area. Have the patient log roll when changing position in bed. Reassure the patient that proper technique is being used to maintain body alignment. Remove the bed trapeze, if present, since use is contraindicated for spinal surgery patients. Enough staff should be available to move the patient without undue pain or strain from the patient or staff. After surgery, most patients need opioids, such as morphine IV, for 24 to 48 hours. Patient-controlled analgesia, PCA, allows maintenance of optimal analgesic levels and is the preferred method of continuous pain management. Once the patient receives oral fluids, oral drugs, such as acetaminophen with codeine, hydrocodone, or oxycodone, Percocet, may be used. Diazepam Valium may be prescribed for muscle relaxation. Assess and document pain intensity and pain management effectiveness. Because the spinal canal may be entered during surgery, cerebrospinal fluid, CSF, leakage is possible. Immediately report leakage of CSF on the dressing or if the patient reports a severe headache. CSF appears as clear or slightly yellow drainage on the dressing. It has a high glucose concentration and is positive for glucose when tested with a dipstick. Note the amount, color, and characteristics of drainage. Frequently assess the patient's peripheral neurologic condition. Movement of the arms and legs and assessment of sensation should at least equal the preoperative status. Repeat these assessments every 2 to 4 hours during the first 48 hours after surgery and compare with the preoperative assessment. Paresthesia may not be relieved right after surgery. Report any new muscle weakness or paresthesia at once to the HCP and record this finding in the patient's medical record. Assess extremity circulation using skin temperature, capillary refill, and pulses. Paralytic ileus and interference with bowel function may occur for several days. Opioids can slow bowel elimination. Assess if the patient is passing gas, has bowel sounds in all quadrants, and has a flat, soft abdomen. Stool softeners, e.g. docusate, colace, and laxatives may prevent and relieve constipation. Emptying the bladder may be hard due to activity restrictions. Opioids or anesthesia. Encourage men to dangle the legs over the side of the bed or stand to urinate if allowed by the HCP. Urge patients to use a bedside commode or ambulate to the bathroom when allowed to promote bladder emptying. Intermittent catheterization or an indwelling urinary catheter may be needed by patients who have problems urinating. Loss of sphincter tone or bladder tone may indicate nerve damage. Monitor for incontinence or problems with bowel or bladder elimination. Immediately report problems to the HCP. In addition to nursing care appropriate for a patient who had a laminectomy, other nursing activities are needed if the patient has also had a spinal fusion. Because a bone graft is usually involved, the healing time is prolonged compared with a laminectomy. Activity limitations may be needed for an extended time. A rigid orthosis, thoracolumbar sacral orthosis, TLSO, or chair back brace, is often used during this period. Some HCPs want patients to learn to apply and remove the brace by log rolling in bed. Others allow their patients to apply the brace in a sitting or standing position. Verify the preferred method before starting this activity. With cervical spine surgery, be alert for signs of spinal cord edema, such as respiratory distress and a worsening neurologic condition of the upper extremities. After surgery, the patient's neck may be immobilized in a soft or hard cervical collar. In addition to the primary surgical site, regularly assess the bone graft donor site. The posterior iliac crest is the most often used donor site, although the fibula may be used. The donor site usually causes greater pain than the spinal fusion area. The donor site is bandaged with a pressure dressing to prevent excessive bleeding. If the donor site is the fibula, frequent neurovascular assessment of the extremity is a key nursing intervention. After spinal fusion, the patient may have some immobility of the spine at the fusion site. Teach the patient to use proper body mechanics and avoid sitting or standing for prolonged periods. Encourage activities that include walking, lying down, and shifting weight from one foot to the other when standing. Teach the patient about any lifting restrictions. Encourage the patient to think through an activity before starting any potentially injurious task, such as bending or stooping. Any twisting movement of the spine is contraindicated. Teach the patient to use the thighs and knees rather than the back to absorb the shock of activity and movement. A firm mattress or bed board is essential. Neck pain. Neck pain occurs almost as often as low back pain, affecting 10 to 20% of adults at any point in time. Neck pain may result from many different conditions, including benign, e.g. poor posture, and serious, e.g. herniated cervical discs. Cervical neck sprains and strains occur from hyperflexion and hyperextension injuries. Patients have stiffness and neck pain with possible radicular pain into the arm and hand. Pain may radiate to the head, anterior chest, thoracic spine region, and shoulders. Weakness or paresthesia of the arm and hand suggests cervical nerve root compression from stenosis, DDD, or herniation. The cause of neck pain is diagnosed by history, physical examination, X-ray, MRI, CT scan, and myelogram. An EMG of the upper extremities may diagnose cervical radiculopathy. Conservative treatment for neck pain in patients without an underlying disorder includes head support using a soft cervical collar, gentle traction, heat and ice applications, massage, rest until symptoms subside, ultrasound, and NSAIDs. Therapeutic neck exercises and acupuncture may also be used for pain relief. Most neck pain resolves without surgical intervention. Preventing neck pain that occurs with everyday activities such as prolonged sitting at a computer or television, sleeping in non-aligned spinal positions, or making jarring movements during exercise is important. Encourage patients to practice good posture and maintain neck flexibility. Foot disorders. The foot is the platform that supports the weight of the body and absorbs shock when the person ambulates. It is a complicated structure composed of bony structures, muscles, tendons, and ligaments. The foot can be affected by 1. Congenital conditions, 2. Structural weakness, 3. Traumatic and stress injuries, and 4. Systemic conditions such as diabetes and rheumatoid arthritis. Footwear is used to 1. Provide support, foot stability, protection, shock absorption, and a foundation for orthotics, 2. Increase friction with the walking surface, and 3. Treat foot abnormalities. Poorly fitting shoes cause or worsen a great deal of the pain, deformity, and disability from foot disorders. Shoes may cause crowding and angulation of the toes and inhibit normal movement of foot muscles. Nursing management, foot disorders. Nursing implementation, health promotion. Well-made and properly fitted shoes are essential for healthy pain-free feet. Women's footwear is often influenced by current styles instead of comfort and support. Stress the importance of having a shoe that conforms to the foot rather than to fashion trends. The shoe must be long enough and wide enough to avoid crowding the toes and forcing the great toe into a position of hallux valgus. At the metatarsal head, the shoe should be wide enough to allow foot muscles to move freely and toes to bend. The shank, narrow part of sole under the instep of the shoe, should be rigid enough to give good support. The height of the heel should be realistic in relation to the shoe's purpose. Ideally, the heel of the shoe should not rise more than 1 inch higher than the forefoot support. Wearing higher-heeled shoes with a narrow toe box will cause hammer toes and corns over time. Prolonged use of improper footwear can also cause a Morton's neuroma. They cause compression of an intermetatarsal plantar nerve, resulting in paresthesia and burning. At first, patients with Morton's neuroma may describe feeling as if a sock is rolled up under their toes. Neuromas usually occur between the third and fourth toes. Acute care. Many foot problems require referral to a podiatrist. Depending on the problem, conservative therapies are tried first. These include NSAIDs, ice, physical therapy, footwear changes, stretching, warm soaks, orthotics, ultrasound, and corticosteroid injections. If these methods do not help, surgery may be needed. Depending on the type of surgery, pins or wires may extend through the toes, or a protective splint may be placed over the end of the foot. After surgery, the foot is usually immobilized by a bulky dressing. Short leg cast, slipper, plaster cast, or a platform shoe that fits over the dressing and has a rigid sole, also known as a bunion shoe. Elevate the foot with the heel off the bed to reduce discomfort and prevent edema. Assess neurovascular condition frequently during the immediate postoperative period. Inserted devices may interfere with assessment for movement. Be aware that evaluating sensation may be hard because the patient may be unable to distinguish surgical pain from pain caused by nerve pressure or circulatory impairment. The type and extent of surgery Determine the orders for ambulation. Crutches, a walker, or a cane may be needed. The patient may have pain or a throbbing sensation when lowering the affected leg. Reinforce instructions from the physical therapist. Teach the patient the importance of walking with an erect posture with proper weight distribution. Report gait problems or continued pain to the HCP. Encourage frequent rest periods with the foot elevated. Ambulatory care. Teach the patient to perform daily hygienic foot care and wear clean stockings. Stockings should be long enough to avoid wrinkling and causing pressure areas. Trimming toenails straight across helps prevent ingrown toenails and reduce the risk for infection. Provide detailed instruction to patients with impaired circulation or diabetes to prevent serious complications from blisters, pressure areas, and infection. Gerontologic considerations. Foot problems. The older adult is prone to foot problems because of poor circulation, atherosclerosis, and decreased sensation in the lower extremities. This is especially true for those with diabetes. A patient may develop an open wound but not feel it because of altered sensation from peripheral vascular disease or diabetic neuropathy. Teach older adults to inspect their feet daily and report any open wounds or breaks in the skin to their HCP. Untreated wounds may become infected, lead to osteomyelitis, and need surgical debridement. If the infection becomes widespread, lower limb amputation may be needed. Teach the caregiver of the older adult who needs help with hygiene practices the importance of carefully assessing the feet at regular intervals. Metabolic bone diseases. Normal bone metabolism is affected by hormones, nutrition, and genetics. When dysfunction occurs in any of these factors, generalized reduction in bone mass and strength may result. Metabolic bone diseases include osteomalacia, osteoporosis, and Paget's disease. Osteomalacia. Osteomalacia is caused by a vitamin D deficiency that causes bone to lose calcium and become soft. The disease is uncommon in the United States. It is the same disorder as rickets in children, except the epiphyseal growth plates are closed in adults. Vitamin D is required for the absorption of calcium from the intestine. Insufficient vitamin D intake can interfere with normal bone mineralization. With little or no calcification, bones become soft. Causes include limited sun exposure, ultraviolet rays needed for vitamin D synthesis, GI malabsorption post-weight loss, surgery, celiac disease, chronic diarrhea, and pregnancy. Residents of long-term care settings may have inadequate sun exposure and thus poor synthesis of vitamin D. Persons with dark skin do not synthesize vitamin D as easily as persons with fair skin. Obese persons are at higher risk because of decreased physical activity. Chronic liver, kidneys, and small intestine disease may contribute to vitamin D deficiency. Long-term use of anti-seizure drugs, e.g. phenytoin, and phosphate-binding antacids, e.g. Maalox, may decrease calcium and vitamin D absorption. Common manifestations are bone pain and muscle weakness. The pain is often worse at night and affects the lower back, pelvis, hips, legs, and ribs. Muscle weakness and progressive deformity of weight-bearing bones, e.g. spine extremities, can lead to problems walking and a waddling gait. Fractures are common and indicate delayed bone healing. Laboratory findings include decreased serum calcium or phosphorus, decreased serum 25-hydroxyvitamin D, and increased serum alkaline phosphatase. X-rays may show effects of generalized bone demineralization, especially loss of calcium in the bones of the pelvis and associated bone deformity. Looser's transformation zones, ribbons of decalcification in bone found on X-ray, are diagnostic of osteomalacia. However, significant osteomalacia may exist without X-ray changes. Interprofessional care is directed toward correcting the vitamin D deficiency. The patient often has a dramatic response when vitamin D3, cholecalciferol, and vitamin D2, ergocalciferol, supplements are used. Calcium or phosphorus supplements may be prescribed. Encourage dietary intake of eggs, meat, and oily fish, e.g., salmon, tuna. Milk and breakfast cereals fortified with calcium and vitamin D should be part of the diet. Exposure to sunlight and weight-bearing exercise are valuable as well. Assess patients who had weight loss surgery to treat obesity for osteomalacia. Any vitamin D deficiencies should be corrected. Osteoporosis. Osteoporosis is a chronic progressive metabolic bone disease marked by low bone mass and deterioration of bone tissue, leading to increased bone fragility. More than 54 million persons in the United States have decreased bone density or osteoporosis. Osteoporosis is known as the silent thief because it slowly robs the skeleton of its banked resources. Bones eventually become so fragile that they cannot withstand normal mechanical stress. Osteoporosis is more common in women. This is for several reasons. One, women tend to have lower calcium intake than men throughout their lives. Men between 15 and 50 years of age consume twice as much calcium as women. Two, women have less bone mass because of their generally smaller frames. Bone resorption begins at an earlier age in women and becomes more rapid at menopause. 4. Pregnancy and breastfeeding deplete a woman's skeletal reserve unless calcium intake is adequate. And 5. Longevity increases the risk for osteoporosis. Current guidelines recommend an initial bone density test in all women over 65 years of age. If results are normal and the person is at low risk for osteoporosis, another test is not needed for 15 years. Women who are younger than 65 and at high risk, e.g., low body weight, smoker, prior fractures, should have a bone density test earlier. Testing should also start earlier and be done more often if a person is at high risk for fractures. Currently, there is not enough evidence that shows any benefit for screening men. Etiology and pathophysiology. Risk factors for osteoporosis are listed in Table 63.12. Decreased risk is associated with regular weight-bearing exercise and adequate intake of fluoride, calcium, and vitamin D. Low testosterone is a major risk factor in men. Peak bone mass, maximum bone tissue, is typically achieved before age 20. It is largely determined by 4 factors: heredity, nutrition, exercise, and hormone function. Heredity may be responsible for up to 70% of a person's peak bone mass. Genetic factors also influence bone size, quality, and turnover. Bone loss from midlife, ages 35 to 40 years, onward, is inevitable, but the rate of loss varies. At menopause, women have rapid bone loss when the decline in estrogen production is the greatest. The rate of loss then slows and eventually matches the rate of bone lost by men ages 65 to 70 years. Bone is continuously being deposited by osteoblasts and resorbed by osteoclasts, a process called remodeling. Rates of bone deposition and resorption are normally equal, so total bone mass stays constant. In osteoporosis, bone resorption exceeds bone deposition. Diseases associated with osteoporosis include inflammatory bowel disease, intestinal malabsorption, kidney disease, rheumatoid arthritis, hyperthyroidism, alcohol use disorder, cirrhosis, hypogonadism, and diabetes. Many drugs can interfere with bone metabolism, including corticosteroids, anti-seizure drugs, e.g., divalproex sodium depakote, and phenytoin, aluminum-containing antacids, heparin, some chemotherapy drugs, and excess thyroid hormones. When one of these drugs is prescribed, teach the patient about the possible side effects. Long-term corticosteroid use is a major contributor to osteoporosis. Clinical manifestations. Osteoporosis occurs most often in bones of the spine, hips, and wrists. Typical early manifestations are back pain and spontaneous fractures. The loss of bone mass causes the bone to become mechanically weaker and prone to spontaneous fractures or fractures from minimal trauma. A person who has a vertebral fracture due to osteoporosis has an increased risk for having a second vertebral fracture within 1 year. Over time, vertebral fractures and wedging cause gradual loss of height and a humped thoracic spine, kyphosis, or Dowager's hump. Diagnostic studies. Osteoporosis often goes unnoticed because it cannot be detected by conventional X-ray until 25 to 40% of calcium in the bone is lost. Serum calcium, phosphorus, and alkaline phosphatase levels usually are normal. Alkaline phosphatase may be increased after a fracture. Bone mineral density, BMD, measurements are typically expressed as grams of mineral per unit volume. BMD is determined by peak bone mass and amount of bone lost. BMD may be measured by quantitative ultrasound, QUS, and dual energy X-ray absorptiometry, DEXA. QUS uses sound waves to measure bone density in the heel, kneecap, or shin. DEXA, considered the gold standard of BMD studies by the World Health Organization, measures bone density in the spine, hips, and forearm. These represent the most common sites of fragility fractures from osteoporosis. DEXA studies are useful to evaluate changes in bone density over time and assess effectiveness of osteoporosis treatment. The BMD test results are compared to the ideal or peak bone mineral density of a healthy 30-year-old adult and reported as T-scores. A T-score of 0 means the BMD is equal to the norm for a healthy young adult. Differences between the BMD and that of the healthy young adult norm are measured in units called standard deviations, SDs. The more standard deviations below 0, indicated as negative numbers, the lower the BMD and the higher the risk for fracture. A T-score between +1 and -1 is normal. A T-score between -1 and -2.5 indicates osteopenia, bone loss that is more than normal, but not yet at the level for a diagnosis of osteoporosis. A T-score of -2.5 or lower indicates osteoporosis. The greater the negative number, the more severe the osteoporosis. Sometimes the HCP uses a Z-score instead of a T-score. In this case, a person is compared with someone their own age, gender, and or ethnic group instead of a healthy 30-year-old person. Among older adults, Z-scores can be misleading because decreased bone density is common. If the Z-score is -2 or lower, it may suggest that something other than aging is causing abnormal bone loss. Nursing and interprofessional management, osteoporosis. Interprofessional care focuses on proper nutrition, calcium and vitamin D supplementation, exercises, prevention of falls and fractures, and drugs. The National Osteoporosis Foundation recommends treatment for osteoporosis for postmenopausal women with 1. A T-score of less than -2.5, 2. A T-score between -1 and -2.5 with additional risk factors, or 3. Prior history of a hip or vertebral fracture. A patient's risk for fracture from osteoporosis also can be calculated with the Fracture Risk Assessment (FRAX) tool. The FRAX considers BMD and other clinical factors when assessing fracture risk. The recommended calcium intake is 1,000 milligrams per day for women ages 19 to 50 years and men ages 19 to 70 years, and 1,200 milligrams per day in women age 51 years or older and men 71 years or older. Foods high in calcium include milk, yogurt, turnip greens, cottage cheese, ice cream, sardines, and spinach. If dietary intake of calcium is inadequate, supplemental calcium may be given. It is difficult for us to absorb calcium in single doses greater than 500 milligrams. Teach the patient the importance of taking calcium supplements as divided doses to increase absorption. The amount of elemental calcium varies in calcium preparations. Calcium carbonate has 40% elemental calcium. It should be taken with meals because stomach acid is needed to dissolve and absorb this supplement. Calcium citrate has about 20% elemental calcium but is less dependent on stomach acid for absorption. It is better absorbed by patients taking a proton pump inhibitor, e.g. esomeprazole Nexium, or histamine receptor blocker, e.g. cimetidine, for acid reflux. Calcium lactate and calcium gluconate are not recommended because they have small amounts of elemental calcium. Vitamin D is important in calcium absorption and function and may have a role in bone formation. Most people get enough vitamin D from their diet or naturally through synthesis in the skin from exposure to sunlight. Being in the sun for 20 minutes a day is generally enough. However, supplemental vitamin D, 800 international units, is recommended for postmenopausal women, older men, persons who are homebound or in long-term care settings, and those in northern climates due to decreased sun exposure. Regular physical activity is important to build and maintain bone mass. Exercise increases muscle strength, coordination, and balance. The best exercises are weight-bearing exercises that force a person to work against gravity. These include walking, hiking, weight training, stair climbing, tennis, and dancing. Walking is preferred to high-impact aerobics or running. Both may put too much stress on the bones and cause stress fractures. Encourage patients to walk 30 minutes 3 times a week. Teach patients to quit smoking and decrease alcohol use to minimize negative effects on bone mass. Encourage patients with osteoporosis to remain ambulatory to prevent further loss of bone density due to immobility. Treatment may also involve the use of a gait aid to walk safely and protect areas of potential pathologic fractures. For example, a TLSO may be used to maintain the spine in proper alignment after fracture or treatment of a vertebral fracture. Vertebroplasty and kyphoplasty are minimally invasive procedures used to treat osteoporotic vertebral fractures. In vertebroplasty, bone cement is injected into the collapsed vertebra to stabilize the spine and improve the patient's pain. This procedure does not restore vertebral height or correct deformity. In kyphoplasty, a small balloon is inserted into the collapsed vertebra and inflated to restore vertebral body height before injection of bone cement. Kyphoplasty is the preferred surgical treatment for vertebral compression fractures. Drug therapy. The recommended drug therapies for the prevention and treatment of osteoporosis are the biphosphonates alendronate, risdronate, and zoledronic acid, or denosumab. Biphosphonates inhibit osteoclast-mediated bone resorption and slow the cycle of bone remodeling. Although a modest increase in BMD is typical, bone remodeling may be suppressed to the extent that normal bone formation is impaired and fracture risk increases. Treatment should continue for 5 years. Common side effects are anorexia, weight loss, and gastritis. Teach the patient to take the medication correctly to improve its absorption. These precautions also decrease TI side effects, especially esophageal irritation. A rare but serious side effect of biphosphonates is osteonecrosis, bone death of the jaw. Its cause is unknown. Those with dental disease, cancer, Paget's disease, or renal disease are most at risk for this complication. Patients should see a dentist before beginning treatment and then annually to ensure good oral health. Alendronate, Fosamax, is available as a daily or weekly oral tablet. The immediate release form of risdronate, Actonel, is given daily, weekly, or monthly based on the dose. Zoledronic acid, reclassed, is given as a once yearly or every other year IV infusion. Renal function tests and serum calcium must be assessed before administration. Other biphosphonates are shown in Table 63.13. Denosumab, Prolia, may be given to postmenopausal women with osteoporosis who are at high risk for fractures. It is a monoclonal antibody that binds to a protein, rankle, involved in the formation and function of osteoclasts. Denosumab is given as a subcutaneous injection every 6 months. Other agents used include the new monoclonal antibody, romosozumab, Evenity. It inhibits the action of sclerostin, a regulatory factor in bone metabolism. This increases bone formation and, to a lesser extent, decreases bone resorption. It's given by subcutaneous injection every month for a total of 12 doses. Raloxifene, Evista, is a selective estrogen receptor modulator, SERM. This drug mimics the effect of estrogen on bone by reducing bone resorption without stimulating the tissues of the breast or uterus. Raloxifene reduces the risk for vertebral but not hip fractures. Side effects, including leg cramps, hot flashes, and increased risk for blood clots, limit use. Teriparatide, Forteo, is a recombinant form of human parathyroid hormone, PTH, that increases the action of osteoblasts. This drug is used to treat osteoporosis in men and postmenopausal women at high risk for fractures, including risk related to long-term corticosteroid use. Side effects include leg cramps and dizziness. Teriparatide is the first drug approved to stimulate new bone formation in osteoporosis. Most drugs only prevent further bone loss. It is self-administered daily by subcutaneous injection from a preloaded pen. Women no longer routinely use estrogen replacement therapy or estrogen with progesterone after menopause to prevent osteoporosis because of the increased risk for heart disease and breast and uterine cancer. A woman who takes short-term estrogen therapy to treat menopausal symptoms, such as hot flashes, may receive some protection against bone loss and hip and vertebrae fractures. We think estrogen inhibits osteoclast activity, leading to decreased bone resorption. Medical management of patients receiving corticosteroids includes prescribing the lowest effective dose for the shortest possible time. Ensure an adequate intake of calcium and vitamin D, including supplements, when osteoporosis drugs are prescribed. If osteopenia is present on bone densitometry in people who are taking corticosteroids, Treatment with biphosphonates may be considered. Paget's disease. Paget's disease, osteitis deformans, is a chronic skeletal bone disorder in which excessive bone resorption is followed by replacement of normal marrow by vascular, fibrous connective tissue. The new bone is larger, disorganized, and weaker. Areas commonly affected include the pelvis, long bones, spine, ribs, sternum, and skull. Up to 5% of adults in the United States are affected by Paget's disease. Men are affected twice as often as women. Paget's disease is uncommon in people under age 40. We do not know exactly what causes Paget's disease. Cause may be viral or genetic. Up to 40% of all patients with the disease have at least one relative with the disorder. In milder forms of Paget's disease, patients do not have any symptoms. The disease may be found incidentally through X-ray or serum chemistry findings of high alkaline phosphatase. Bone pain may develop gradually and progress to severe intractable pain. Other early manifestations include fatigue and progressive development of a waddling gait. Patients report becoming shorter or their heads are becoming larger. Headaches, dementia, vision deficits, and loss of hearing can result from an enlarged, thickened skull. Increased bone volume in the spine can cause spinal cord or nerve root compression. Pathologic fracture is the most common complication and may be the first sign of Paget's disease. Other complications include osteosarcoma, fibrosarcoma, and osteoclastoma, giant cell tumors. Serum alkaline phosphatase is markedly increased in advanced disease, showing high bone turnover. X-rays may show curvature of an affected bone. The bone cortex becomes thicker and irregular, especially in weight-bearing bones in the cranium. Bone scans using a radiolabeled biphosphonate show increased uptake in the affected skeletal areas. Interprofessional care is usually limited to symptomatic and supportive care, with correction of secondary deformities by surgical intervention of braces. Biphosphonate drugs are used to slow bone resorption. Zoledronic acid may be given specifically to build bone. Calcium and vitamin D can decrease hypocalcemia, a common side effect of drug therapy. Monitor drug effectiveness by regular assessment of serum alkaline phosphatase. Calcitonin is an option for patients who cannot tolerate biphosphonates. Human calcitonin inhibits osteoclastic activity, prevents bone resorption, relieves acute symptoms, and lowers serum alkaline phosphatase. This drug is available as a subcutaneous injection. Salmon calcitonin is one form, has a longer half-life and greater milligram potency than human calcitonin. Response to calcitonin therapy is not permanent and often ends when therapy stops. Pain is usually managed with NSAIDs. Orthopedic surgery for fractures, hip and knee replacement, and knee realignment may be needed. A firm mattress can provide back support and relieve pain. The patient may need to wear a corset or light brace to relieve back pain and give support when upright. Teach the patient to correctly apply the device and regularly examine the skin for friction damage. Discourage lifting and twisting. Good body mechanics are essential. Physical therapy may increase muscle strength. A well-balanced diet is important in management of metabolic bone disorders. Vitamin D, calcium, and protein are especially important to ensure available components for bone formation. To decrease risk for falls and related fractures, teach the patient to use an assistive device and make environmental changes, e.g., do not use throw rugs. Gerontologic considerations. Metabolic bone diseases. Osteoporosis and Paget's disease are common in older adults. Teach patients proper nutrition to decrease risk for further bone loss. Keep the patient as active as possible to slow demineralization of bone from disuse or extended immobilization. Because metabolic bone disorders increase the risk for pathologic fractures, use extreme caution when turning or moving the patient. Hip fractures, in particular, may decrease quality of life and lead to admission to a long-term care facility. A supervised exercise program is essential to osteoporosis treatment. Encourage ambulation if the patient's condition permits.